And I'd like to welcome everyone back and thank you all for coming and get started with the Bishop's discussion of what his priorities for the healthcare in Sierra Leone are.
Well, thank you, Cindy. Basically, we have quite a few, health and medical priorities for our next 10 years, including providing the highest quality health delivery system in the country, emphasis on community, maternal, and child health practices, rehabilitation of all our health centers in the country. And here the good news is that we're almost like 80% through that process. Through your hair, we're almost 80% through that. Training and recruitment of qualified doctors, nurses, and other health workers. Transforming the Mercy Hospital into a 150-bed hospital, and also to transform Mercy Hospital into a teaching hospital, and which means that we will be attaching to the Mercy Hospital a school of nursing. Transforming the Kisii Hospital into the major child and maternity health center in the country, and finally making healthcare accessible and affordable, especially to the poor. Those are a few of those priorities, for our health sector.
Do you have the three top that would be your priority, or would you put them in order of priority?
If I were to put this in priority, I would say rehabilitation of our health centers. And when I say rehabilitation, it also goes, of course, with resourcing of those health centers. Providing the highest quality health delivery system in the country, which will also include, of course, equipping those hospitals with trained and qualified health practitioners like doctors and nurses. And then we will also, our next priority in that order is transforming the Mercy Hospital into a teaching hospital, and with the provision of 150 beds. And finally, the Kisii Hospital, the Kisii General Hospital, to be a model hospital for child and maternity health care in the country.
Sister Beatrice, can you give us your perspective on some of the priorities that the Bishop has?
Based on the priorities that the Bishop has listed, I want this body to know that the following organizations and partners are currently working in the area of health. And they are, from Indiana, we have Operation Classroom and Operation Doctor, Christopher Blind Mission from Germany, Then Eye Care, Africa Uplifted, Helping Children Worldwide, the Norwegian NGO in Norway, East Ohio Conference, the German United Methodist Church, UMCO Health Global Ministries, and Wells and Sanitation Program. I think that comes out of Indiana also. Am I right? Lee Weaver is heading that program. Pennsylvania. Lee Weaver, I think his representative is here. I will not speak for these programs, but I know all of them will be able to speak for themselves, telling us what they are doing in Sierra Leone. I'm very thankful that when Bishop and myself consulted to come up with a Vision 2020, we put those priorities as he has listed.
Thank you very much. Is there any specific ways that you see the organizations that are represented here today helping you with specific projects?
I just do not want to go into, because I see on the program there is space for each organization to see what they have been doing. I have a list of what everybody has been doing right here with me, but I want to give the opportunity for them to say it. They have been very, very good. And I can say From 2006 to 2012, there has been very big change in the healthcare program for the Sierra Leone Conference. And I want to take this opportunity to thank all of you. You know, I have had people behind me pushing me, apart from Bishop Yambasu, people like Shannon Trilly. I'm sorry, Shannon, I'm putting you on, on the front. But they have pushed us to achieve what we are achieving. And I'm sure they will speak for themselves.
Bishop Yambasi, with the changes that have been happening since 2006 to now, do you think that the priorities, even in the last 2 years, have changed any?
The priorities have really not changed. In fact, what we're doing right now is to consolidate those priorities. There has been a tremendous overflow of enthusiasm from all of our partners, every one of them trying really to just chip in to do what they can do as God leads them to do. But some striking, amazing, phenomenal changes are really, things are really happening in Sierra Leone, you know, especially in terms of when we look at the present healthcare delivery system in the country, looking at where we came from with all of what is happening now in the country. We do not, as United Methodists, actually claim 100% responsibility for all that is happening, but I think we are a major contributor, a major partner with government in the health delivery sector. And I would not say we are the leading, but I think we're providing the leadership for the rest of the other denominations or healthcare deliveries in the country to really move to follow us. So I can simply say that when it comes to a healthcare delivery system, in terms of private institutions or religious institutions, the Sierra Leone Annual Conference leads and the others follow.
Dr. Mark, can you give us your perspectives on the priorities and the things that you're seeing?
Okay. Thank you. I find the priorities pretty interesting here. What I have linked two of the priorities. Priorities 1 and 4 are interrelated. That is providing highest quality healthcare system and training and recruiting qualified health personnel. The goal of us healthcare people, when we deliver healthcare, is not only to cure diseases, to improve the quality of life and as well as prolong life. And what do we need to do this? We require the best expertise, trained and qualified, and we also require the equipments in order to achieve this. We're going to need diagnostic equipment such as an ultrasound scan, an X-ray facility, and along with that, we also require the required personnel. Also, the priorities 2 and 3 are also interrelated. That is emphasis on community and maternal and child health care and rehabilitation of our health facilities throughout the country. My bias is public health. If our health centers were located in very critical areas in the country where government presence wasn't there. Prior to the war, the European Union did an assessment, and they found out that 1/3 of all healthcare is provided by church-related hospitals in Sierra Leone. And of course, like you hear the bishop, of this 1/3, we have been leading, the United Methodist Church. So, for instance, talking about community, reaching out in our communities, rehabilitating these health facilities out there is like saying, okay, we are going to reach out into these communities where other health facilities are not available. Because if I stayed at my hospital in Freetown, and this woman comes to me with a sick child, malaria, and another one with diarrhea from this community, and I stayed hospital-based, they come over to me. There's a cost-effectiveness thing involved there, and my time and the community's time. So if I make it hospital-based, purely curative, my impact will not be as significant and as cost-effective as if I went out into these communities to see where these malaria cases are coming out from, where these diarrhea caseloads are coming from, and address it right there on site. So I believe, looking at it from that perspective, these priorities are pretty much in place. And so far, so good with the partners with whom we have been working. That's my perspective.
You pass that down. Shannon, could you tell us what UMCOR's priorities are for the work in Sierra Leone and how all of the ministries here can help you?
Thank you. And thank you to all of you for having me here. And it's an honor to sit on this panel this afternoon. Looking at this list of Bishop's priorities, the Sierra Leone Annual Conference's priorities, I would lift up the rehabilitation of our health centers, the community-based centers is how I would interpret that. And the reason is not to rehabilitate them for the bricks and mortar that they are, but because those centers serve as a nucleus for outreach into communities. I'm going to go to a different thought and loop back, so go with me for a moment. The gift of seeing Mercy Hospital is the gift of vision. It's what is possible in Sierra Leone. But as a technician, I say, or in addition to that vision, I would say, we need 10 or 20 Mercy hospitals at that level of care. You all are pushing what is possible, high and access to high-level health care. But the truth is that in the short term, that is not an option for everyone in Sierra Leone. But there are community-based approaches that in the short term, which is what we've seen, for example, with the immunization and the malaria and nutrition programs that we pushed out together in 2010, that in a very short time can prevent preventable illness and death. And so I really lift up kind of what Dr. Mark was starting to speak about and articulate that the focus of UMCOR, and I believe right hand in hand with this list, would be a focus on those community-based rural outreach centers and building them up. And it's those centers like Manjama that connect into Mercy. But again, the value being in education and prevention. It's a beautiful arc from the conversation we had, the panel before. Because really, health is about washing your hands before you cook food right now. When millions of children across the continent are dying of diarrhea, that's not okay. I think our denomination is saying that's not okay. And as called by the Global Health Initiative and called by Imagine No Malaria, is simply a call not to just do malaria nets, or not just, but to interpret global health as short-term, high impact, and based absolutely in the vision of the community to do what they can do immediately to make their health situation better. So that would be the focus I would lift up for health.
Can we pass the mic down to Dawn? And I'd like to ask Dawn, can you share what your organization is doing in Sierra Leone in regards to healthcare and which of the Bishop's priorities you're most interested in?
Sure, thank you. Sierra Leone Health Partners is a group of people who have come together to coordinate some volunteer activities. We relate pretty closely to Operation Classroom out of Indiana, and Operation Doctor, which has a health emphasis. I would say that our purpose is to do long-term development through short-term teams, particularly relating to the field of healthcare. We want to work in such areas as infrastructure and human relations, in administration, and in financial development of resources. We have three other emphases that have developed out of it because of working in a community setting. One has been a food program out of Bioma Women's Health Cooperative that just happened, and it's been a marvelous thing to see take off. And then an animal husbandry nutrition program at Tayama School. But our major emphasis has been in terms of the work primarily with Kissing Hospital, although we've worked with the clinic at Tayama some. In the area of infrastructure, we've done a lot in electricity. We installed a new generator. And Dennis, we've got another one on the way as a backup. We put in a system for night lights at Kissing Hospital. Then we've replaced it just this last year with a smaller generator because the inverters and batteries are terribly expensive and hard to maintain. We work with things like upgrading the laboratory and providing equipment and training. And in the area of infrastructure, we've helped develop the physical therapy department. We've helped set up the Well Baby Clinic. We've helped try to do some work with antenatal moms and to do areas that are going to strengthen the hospital's program. Human resources, it's what you might think about medical continuing education. We worked with the hospital. What are your needs that you see? Then based on those needs, we try to recruit medical personnel in those fields. And then they go for 1, 2, or 4 weeks to work with the hospital staff, and so on and so forth. We work in the areas of management and financial resources. I think what our priorities in looking at the bishops, obviously we are concentrating on Kissing Hospital because that's where we've worked and that's where we felt God's call. But it looks rather obvious from the bishop's priorities that there's some times of transition going on. As we look at our own setting in Indiana, there are transitions going on. So I'm not really sure where we would tie into those priorities. One of the things that I think we would like to say that would be very important in the area of development is that with these goals, there ought to be, or we would certainly encourage, some developmental stages. You know, it really is important to say, all right, we want to develop community health care. All right, how are we going to do that? You know, how is that going to work out? How do you know what's going to happen? We would like to see such things as, how can there be some more community involvement? The Nothing But Nets program was wonderful because it went into the Bow area, it involved people, it was organized, it didn't just happen, it worked with people. And I think when you start working in the area of healthcare, that's so important. And I would hope that we would see that kind of cooperation, that kind of development, and that we would ask the hospitals, for example, if you're going to become what is here listed as your priority, there ought to be a 4 or 6, maybe even as much as a 10-year strategic plan to get there. Because planning passively ends up with inertia, so that you end up suddenly saying, oh, we haven't gotten anywhere yet. Thank you.
Thank you. And speaking of community-based primary health care, Beth, can you tell us what the East Ohio Conference is involved in Sierra Leone?
East Ohio Conference, as the clinic component of our 3Cs task force, is committed to community-based health care training, and specifically that started and still is at Monjima United Methodist Health Center. And we are continuing to uphold that as one of our priorities. and that involves, doing some possible maintenance work at the health center and the duplex behind it. But our primary emphasis right now, from the health center perspective, is to keep it afloat during these times when the patient's load has gone way down due to the government's giving of free care to under 5s and pregnant moms. And we have done that through an agricultural program, which we're raising Benny, which is sesame seed, and that is one of the nutritional components of Benny Mix, obviously. And we are doing a potato garden. We are doing bread baking. They are doing moringa production, which the trees have been growing there since 2005. And we are doing goats, and they have been able to give goats to 5 village TBAs and continuing to increase the herd at Manjima to sell for celebrations of both Muslims and Christian faith people. So sustainability of the healthcare is one of the priorities, and I was excited to see Derek's display that there's another possibility with the solar charging of cell phone batteries that we can maybe do, and those types. So we're constantly trying to, as I brainstormed with the staff there a year ago, come up with things that are going to help them maintain, that do not take help from the outside to continue to do. Now, from the community-based health training, we have done that at Manjima since 2004 and have had courses while I was still there for the 2 years, 2004 and 2005. We did community-based healthcare training for people from Kono and Tayama and around Manjima, Kanama, whoever. It was a countrywide program. Lay, semi-literate women came in and were trained. The initial courses were 4 weeks, and we emphasized the things that UMCOR Health, community-based health training guidelines emphasize, and that, of course, is nutrition, safe drinking water, hygiene, environmental hygiene, which includes latrines, etc., immunizations, and disease prevention and recognition of the primary diseases. We also did in the community-based health training that we did what we called survival projects. The women learned how to bake the bread. They could do that when they went back to their villages. They did bead making, they did bead work. We did soap making, which is another project we need to possibly pick up on, making lye soap to sell. And that is what we are doing in community-based health training. And as both, as I've listened to the conversations that have gone on to this point in this panel, we have accessed people from Kissy to come and help with our community-based health training, and there's no reason that Kissy people can't access the people from Manjima to help them reach out into their communities. I mean, we have a good setup here because we have a collaborative effort with HIV/AIDS program. We always have Ernest come up, and with Kadi comes up with the nutrition program. She taught us how to make yogurt, and this can be a reciprocal thing. It would be a slightly different environment going into an urban setting, but I'm sure it's something that we could help with. It is cost effective, as was mentioned. We need to reach out in cost effective ways, and to do that we do with motorbike and a 4-wheel drive vehicle, but there's some villages that you do the motorbike to. So that was the things that I mentioned here. And we need to coordinate communications within the whole of Sierra Leone with the healthcare facilities and not duplicate effort and I hate to use the term, but feed off of each other instead of eat each other, if you know what I mean. It's a difference there. And so we need to do that, and we need to coordinate things like water wells. From East Ohio perspective, we're looking for projects to do. So some of the things that we might be able to do in the village area around Manjima as a base site to start out, there's 20 villages, probably I don't know how many have wells now, but no more than probably 10 at the most. Half of them have wells, and that's probably an exaggeration. But we can do wells. We can help the latrine building in those areas. And we can also, as we look for nursing schools, in whatever area, nursing school or schools are, it could be the site for the training for the community-based health component. And East Ohio would look toward maybe doing a dormitory if that eventuality would come about. I can't speak to that, but that's part of our future discussions as projects evolve, the possibilities. So is that what you wanted from the community-based? More than you wanted, I'm sure.
Thank you very much. Can you pass the mic then to Doris? And Doris, can you tell us what Africa Uplifted is doing in the way of healthcare?
Sure. We are very focused in rural areas. In fact, that has always been our focus and probably will continue to be our focus, because we feel that in these small villages that are really off the beaten track, the availability of healthcare, the affordability, and the accessibility is simply not there. So we feel that it is our mission to bring that to the small villages, and in doing that, we have set up probably more of a nursing type clinic component using nursing and community health workers, because physicians simply are not available. So we have trained community health workers that actually do all the teaching to their communities. It is it's a model that is based on the community. We empower the community to make their choices for their own health care. We teach them how to teach their own villages, so that basically we serve as support. We are the support person. We are the people, yes, you can do this, but you have to be the ones to teach it. You have to take ownership. It's your clinic. It is your health. It is your families. That is what makes it, in our model, that's what makes it really work. We really, so when I look at what the bishop's goals and stuff are, where we really key in, obviously, is the last one, making healthcare affordable, available, and accessible to everybody, most particularly to the people who are most remote. And then the second thing that we do is that I think we really focus on maternal child care. But we do this through working very closely with the TBAs, working closely with the 1 or 2 midwives that we have, and then with maternal child health aides, because that is all we have. And so we are often, we are what I always call, we're the first call. You know, we see people, we treat them for what we can treat them for, and then we move them on if there's something that we are not, equipped to do. So we really, we focus on a lot of community education, a lot of wellness promotion and disease prevention, and we feel that by just addressing clean water, sanitation, hygiene, nutrition, we can prevent, or at least decrease the amount of diseases and illnesses that are the biggest causes of morbidity and mortalities for under 5s. And that truly has been our goal and probably will continue to be our goal. So that's where we're at, and that's what we really enjoy doing. Well, Thank you.
Thank you, that's great. Kirsten from Helping Children Worldwide, can you tell what Mercy Hospital's been up to?
Sure. Well, Mercy Hospital has really been in a process of development at this point. We recognize that in Sierra Leone, and particularly in Bo, that maternal and infant mortality remains a tremendous problem, as do infectious disease, as well as we're seeing increasingly sort of non-infectious diseases are a significant cause of morbidity and mortality in Bo. And so what we're really focusing on is, first of all, understanding in a very concrete way, in a very data-driven way, what the issues are. Because we feel that without the data, that we really can't have any impact, dramatic impact, and understand how we can continue to improve. Just to tell you a little bit about an anecdote, if you will. We were there in May, and we went out to visit a community-based primary care unit, where Edmund, who was the community health officer, was and continues to put up on the wall every month what are the incidences of various specific infections as well as ongoing health problems. And it was amazing to see that he really understood what the issues were and what in his small area and could have a dramatic impact. And so we recognize that it's really the data that's driving what we need to do and how we continue to improve that. So the question then becomes, how can we expand that, and how can, at Mercy Hospital, how can we build that into the projects that we're doing and the ongoing work that's being done? And so we've really begun to look at different, not only using cell phone technology and SMS texting to send small amounts of information on a regular basis, but also thinking about how we can use that to expand to not only the hospital, but then thinking about developing a surgical-based surgery center for patients, not only to be able to do C-sections, but also to develop and support other patients. And so those are really the big things at this point. It's really looking at how we can do screening. We did the first breast and cervical cancer screening there in May. We recognize the challenges of doing that and recognize the importance not only of data, but also collaborations, not only in Sierra Leone, but here in the States, as well as internationally. And I think that's really going to be the future for Mercy Hospital as we continue to support the patients and in a teamwork manner. So that's really what we're doing.
Thank you. We'd like to open the questions to the floor now. If anyone of you have any questions, if you could step up to the mic so that we can hear and everyone else can hear, then that would be great. I see Dawn rolling down to the mic.
Good afternoon. I'm one of the collaborative people that you were just referring to with Mercy Hospital. I'm Dawn Kiltz. I represent 3 groups, and we are not part of the UMC. We are all non-religiously based groups, but we have come in contact with Mercy Hospital, and I'll just say West Africa Fistula Foundation, which works currently out of Bow Government Hospital, and the Long Island University Health Mission Group, which works with West African Fistula Foundation, and then also the Alliance for Global Health Projects. So these are the 3 projects that I currently represent. But not to do the story because it gets too long and so forth, but serendipitously, if there is such a thing, I met with Cindy when she was going on a trip in May, and we started discussing many different things. But one of the things that I'm thrilled to see on the agenda is a nursing and allied health school setup of some sort, hopefully Mercy Hospital area, in that area, because this is something that's really drastically needed. I had worked for a while with Jala University there to set up a nursing curriculum, which Cindy has seen, and we had some difficulty with them providing resources, but particularly a true baccalaureate nursing education program, initially an associate degree program, then build into a true baccalaureate in addition, and my dream, and Cindy, this, I know this is not in, we haven't had this discussion, but my dream also, and it goes back to what you've said, is nurse practitioner education, because in my mind, that is, needless to say, I are one. So that's why I have the preference. But I do think that that could serve us a lot in that area, and I would look forward to that. In addition, one of the things, I probably had one of the best discussions of my entire life, very seriously this May, when about 4 different groups of us got together and discussed different projects and what we want to do. And I think one of the important things, that conclusions we came to, is that many of us are beginning to recognize that while we don't want to lose our identity, we don't want to lose who we are as individual groups, that it is time perhaps to become a little less territorial, to become a little more collaborative, and to look at the common problems and how we can all contribute Many people, financially, of course, I mean, that's always the basis for things, but also with support staff, with equipment, with education facilities, these different kinds of things where we could really build a very, very strong operation, and particularly, I'm thinking in the Bow area because that is the area where I work. And I think that goes with the school. I think it goes with some interim planning on our way to perhaps separate institutions that we all may want to build eventually. But there are some really exciting things I think we can do if we can all decide that sharing is good for our souls and that we really could move with that. So I would also encourage that very, very strongly. That I've said to someone before, there are millions of NGOs and millions of dollars in Sierra Leone, and everybody protects their territory, everybody has their agenda. Certainly groups that collaborate very well, I'm not minimizing that, but I think it's really time for major groups to look towards long-term collaboration.
Thank you, Don.
It's okay. I just wanted to add on to what Don was saying and share an initiative that we're working on. I'm just coming back with news for this health team today, so I'm talking, some of it might be a surprise to them, but it's part of an ongoing conversation that we have, recognizing that there's a lot of activity that's happened in Bow in particular out of the last 2 years. So whether it's the Maternal and Child Health Week, which was the NETs and the immunizations, and vitamin A and polio, or the actual outreach work into the Manjama community from Bow or into Tayama, all of our areas that we work in. And one thing, based, for us, from the UMCOR perspective, the NET outreach was a testing of the outreach system, of how we work out of Bow, and how does that chain of referral work? Because we've all got to, instead of being territorial, pass the baton better, because that's how the health system works. And so one opportunity, I mean, the benefit of the National Net Distribution and Maternal and Child Health Week that I've seen and didn't realize until today was the opportunity that it brought to the United Methodist Church of Sierra Leone health team, that organizations, as you all know, Tony Blair Foundation, I heard about MSF today, are now seeing not an international NGO, but a local church community rise as leaders, and not just leaders, effective leaders, proven to be more effective based on the data from the net distribution than our other partners in the country. So because of that, an organization called Cure Americas, do you know that, Dr. Edelman? Yeah, Dr. Perry, based out of Hopkins, is doing work. We piloted our partnership with them of UMCOR through Ganta Hospital and the NENWA, those of you that know Ganta, the NENWA Community Outreach Program. And very quickly, what it did is what we're thinking it could do out of Bow is take those community educators and TBAs. I mean, we throw community health worker as a term around as if we all agree on what that means, and even governments and ministries of health are trying to define what that is. I see us between Bow and Manjama trying to define what that is right now, or out of Kissy and into other communities. So Cure Americas came to me, and I was with the Sierra Leone health team and 14 other African health teams in Accra 2 days ago, and came to us with an opportunity to do, they call a small pilot, for us it's a big pilot, in order to help us sit down and really walk through our community health worker and outreach system as based in Bow and work out who does what, and the areas of focus would be primarily to achieve data-driven demonstrable results in maternal and child survival, focusing on interventions, malaria, HIV and AIDS, nutrition, all the way down the development line, if you will, to micro-lending, because we've got to incentivize these community health workers over time. And so what I would like to propose to this group is, can we use this NGO coming to Bow as an opportunity to sit down together and work out the chain, along the chain where we all work? Can we work out what health workers go where and do what and who's in charge? And the other party that will have to work this out with us is the Ministry of Health also. And so I actually think very soon and in play, there will be an opportunity for a major regional and national level maternal and child survival initiative that includes all of us. And if we're looking at, for example, a surgical center based out of Mercy, you know, if we can teach our community health workers how to screen for malnutrition and malaria, they sure can be taught to screen for other issues that are specifics to the specialization and vision we have for where Mercy can go, for example. So I just think that there are some really exciting synergies that are happening. But what I also see or feel as I sit in on all the conversations today is that we have to get better at communication and coordination. And I really want to lift that up as my request, and I'm not sure how we'll follow up from this year's meeting in doing that. We're going to have to figure it out if we want to optimize what could be, you know, a multi-million-dollar program, which we don't want to talk about these in dollars, but that's one way to express how big of an opportunity this is for our community outreach networks. So that's really what I wanted to share with you all, is this opportunity to work out what we're all doing and how.
My name's Kathy DeCreedy from the East Ohio Conference, and I have been to Sierra Leone twice and do most of my work in West Africa and Liberia. But the thing that I was excited to see come out of General Conference was the conferences that had partnered with the Imagine No Malaria campaign. And Bishop Bickerington was excited to share the list of, I think, 10 or so annual conferences. I was very disappointed, though, not to see any conferences from Africa or from Asia on that list. It was all American annual conferences. And I think that if we're really going to solve the problem of malaria, we need to get countries like Sierra Leone on that list of being financial partners, of being, and part of that is some of our jobs as we go and we do UMVIM trips there. How do we host Imagine No Malaria projects or events while we are in country and educating the young people that are in our schools? And how do we partner with those folks in Sierra Leone, Liberia, or wherever we go to host Imagine No Malaria programs right there with them? We do a lot of talking about malaria right here in this country, and they do a lot of experiencing malaria. And so we need to take our passion for the cure over there and continue to spread that around that preventative health care. And so that was what I would like to share.
Okay. Yeah. I've been given permission by the bishop to speak. Bishop Yambasu is actually the, tell me if I get this right, College of African Bishops representative to the Imagine No Malaria Executive Committee. So he sits on the committee with Bishop Bickerton. And as such, and it actually is helpful, where'd Kathy go? I'm looking for her. It was helpful that you lift that up because from a program side, we're always kind of, with communications, you kind of always fight what the message is. But Bishop Yambasu in the Sierra Leone Annual Conference actually was the first African annual conference to fundraise at their annual conference last year in order to contribute to Imagine No Malaria. It's helpful to know that that's not being communicated strong enough. I think that, and again, I think the involvement of the African church in Imagine No Malaria is so much more profound than what's getting out there. And so be assured that it is there and that at this cycle of annual conferences that are starting in West Africa, March, April, that will be a much larger part of the program, that they also are fundraising and contributing to the effort. I think what is scary to me, I kind of wear two hats, the fundraiser on this side of the ocean and then implementing on the other, is that this denomination committed to $75 million. And then we as UMCOR, being the facilitator for our African churches, pushed the African churches for 4 years to get ready to distribute $75 million to the continent of Africa. We at that time had never moved that much money throughout a region before. For a disaster, we know how to get money there, but for a region and for development versus emergency response, we had not. And so we worked for 4 years to develop, we have a poor, boring name for it, but we just call them these health boards. So these bodies of governance in each of the African Annual Conference and cultivate the donor conversation skills. So our health teams knew how to address malaria. They know exactly, they don't need us to tell them why their communities are dying or what interventions are needed or how to work with government. The experience that our African churches needed was how to write proposals and design programs that a donor would accept, because our partners in Imagine No Malaria were Bill and Melinda Gates and the UN Foundation, who pushed all of our capacities in terms of how you request and manage money and program and demonstrate impact, which we're really not good at. I mean, and much of the development world is not good at. So there were skills that all of us had to develop. So for 4 years, we pushed our African church to develop these skills and form these organizing bodies to implement health programs. And now there was a point where the denomination, and this is what worries us moving away from area of focus, we've raised about $23 million out of 75. But we made a promise as the American and Western church to the African church that if they put in all of this work, I mean, how much did I annoy you guys going over there? All the time, pushing them to organize and prepare and do pilot programs like the distribution. They did their part. The African church did their part. And so my fear in a shifting focus of our church is that we're going to move on without fulfilling what we promised our brothers and sisters in the continent that we would do. And if they develop the skills to move the resources, that we would find the resources or help them find it. So I think that just goes hand in hand with your comment about, are they there? I'd say yes, they are, in more ways than in money. But my urgency now is on this side of the ocean, that the U.S. church will fulfill the commitment and agreement we made at General Conference 2008 to raise $75 million for this fight. So.
Thank you. That's a lot of information that I wasn't aware of too, so I think it helps for everybody to understand. Dr. Conte? Oh, Carol.
Hi, my name is Carol McIntosh, Dr. McIntosh. I went down with Dr. Edmondson in May. That was the first time going into Sierra Leone. Actually, the first time entering the African continent, so it was, that was unbelievable. But I just really just came up really just to underline the whole talk about collaborative effort, because you already have a variety of different groups looking at health and looking at education in different eyes. And to bring them together before leaving this conference, somehow, some way of making sure that this is an ongoing thing. Because just the same thing when we did the cancer screening in May, and in the sense it was the first time the cancer screening was being done in Boa and Sierra Leone, and seeing the number of women that come out, granted it was a small number, but you can take that and then move it to say, this is already being done in Zambia, where they were evaluating for cervical cancer and what the treatment's there, and that's already determined. So you can say, all right, well, let's start in Sierra Leone, not reinventing the wheel, but to say, what are the other programs? How can we bring it here? The collaborative effort between the different groups, because we're talking about bringing in generators. If you're talking about going out and teaching community health workers, if you're talking about, well, let's make it sustainable, just doing the doctors and other community providers. Mr. Edmond, in that small area, if we can clone him and put him throughout Sierra Leone, that would be fantastic. So I really just wanted to just underline, please do determine what collaborative effort between the different groups before everyone leaves, because there's so much that's available in the sense of just even bringing in what was being done in Zambia, how can we replace it or replicate it in Sierra Leone? But to not leave here without making sure that every group at least meet or talk every 2 or 3 months to figure out how can you improve the healthcare and education in Sierra Leone. I just want to just emphasize that.
Good afternoon. I just want to thank all of you, panelists over there, for all you've done for Sierra Leone in the health field, as well as all you partners as well. We, Pan-African Rural Health and Social Services, do certain things in the medical area as well. We're doing medical supplies. We're working on, our focus right now is to build a clinic, a community clinic that will serve the community we're serving right now. Sanitation, we do outside toilets, we do water wells, We still need a lot more to do, but we are doing all that. What I want to bring to the attention of this whole body is that because of our limitations in Sierra Leone, in therapeutics, and all the facilities we need in medicine, I want us to emphasize preventive care, which is what OMCO is doing. I applaud you on that, and all the other people are doing. Now, we need to know what we have, what we don't have, and start from a point where we can go forward that will be to the advantage of the communities. We need to emphasize immunization. Immunization will help a long way. We know what our limitations are. So if we just prevent, it will be a great thing. If we can think of that when we're trying to partner and raise funds and help folks, it will be a great thing for the communities back in Sierra Leone. Well, the training, of course, is necessary. But as we know, young ladies are dying left and right, and the number is not decreasing yet, maybe in a little sector, but nationwide it's not. So maternal care is very important. Neonatal death rate is not reduced yet. Infant mortality rate is not reduced either. So we need to address those when we are training our nurses, as well as our physicians. Now, we also need to consider diagnostic facilities as well. A lot of our diseases go undiagnosed, and that's why people are dying from a lot of diseases, most of them preventable. So I want us to think of that when we're trying to partner up in our fundraising and sending whatever equipment we're sending, to know that we need these opportunities in order to be effective in giving medical care. I thank you so much.
Thank you.
When you mentioned neonatal care, we are in conversation with the Seventh-day Adventist, Dr. Ike. He visited Sierra Leone, and he had been doing training of nurses and health staff in neonatal resuscitation. And we are in conversation to collaborate with government so that our nurses, some of our staff will benefit. So we are not forgetting that area, because we still remember that we have the highest neonatal and infant mortality in the world. And we are working towards getting people who will help us to really train our people who are working in those areas. You see, Dr. Ike Ferguson has been in conversation with us, and maybe in the new year, he's coming to Sierra Leone to train nurses, midwives in that area.
That's a wonderful effort. It bothers me to see some of those needless deaths. And neonates are dying. The problem is we don't have nurses that know how to take care of the mother after birth, the neonate, the first 30 days of life. Very delicate. They need trained personnel to take care of those. Otherwise, we'll lose a whole lot of them like we're doing right now. So we actually need to take that into consideration. Thank you.
Cindy.
Thank you. Kirsten?
Yep. We're very fortunate to live in the technology age of video conferencing and the ability to transmit images. And so one of the things that we hope to do is to really to really maximize the utilization of that technology. In terms of thinking about how we can transmit images through cell phones from TBAs back to Mercy or back to other hub center to help provide information and help to support the TBAs to identify those patients who need to come in to Mercy or to come into Kissy, because that's really the key way of not only being able to help patients, but also to provide education so that then in the future they're able to understand what needs to be done. It really then takes that one step further in the diagnosis of specific diseases, of having that technology to be able to look at tissue slides, to be able to look at pathology, to be able to identify specific organisms to help direct treatment. So it's really not only providing education, but being able to use video technology to help support the work that's being done.
Thank you. Does anyone else have a question? Yeah, go ahead.
I have a question and a couple of requests. I saw that in our materials, and as I was reading through different projects last night, that the maternal death rate is 1 in 7, 1 in 8, and 1 in 21. Can anybody up there tell us what it might be at this time, or do we really know what the death rate is of mothers in childbirth? Our publicities have different information if you read them.
Yeah, it was actually just 4 years ago when I got involved in Sierra Leone, 1 in 8, but my latest understanding is it's up to 1 in 21 now, so it's improving.
That's marvelous. That's cause for celebration. Yesterday we talked about making some lists where people could say, I want to be on the agriculture group list, I want to be on the primary education list, and I want to know who's where.
Right.
Have you all come up with some way that we might do that? I keep realizing our time is running out.
I need to find Mary Beth. We can put something out this evening. Everyone's staying for the dinner. We can get something out to get everyone to sign up. And then I think really what we need to do is also help work with the Sierra Leone Annual Conference website to put all the organizations that are working together on their website, so that if someone goes to look for them and they can see who's working within the country, and maybe help coordinate efforts. But we'll need to get, Mary Beth has contact information for all of you, so we can help with that. And then we'll try and get who wants to be interested in which fields lined up tonight.
I don't know what categories you need. I mean, I know the two that I got to see, but everybody has different categories, I know. The other thing is, can the Sierra Leone website handle that, or will they be able to process that, or will that be unmanageable?
Do they have to, does the Sierra Leonean Conference have a website? Or is it just through the GBGM? You told me before there wasn't.
It's really not a website. It's just somewhere that says Sierra Leone. It's not been done yet. So we are working with GBGM.
Yeah.
Yeah, GBGM or electronic communication for them to do that. Hopefully by March, we're going to have that done.
So you don't have a website
We
right
don't
now?
have that.
In the meantime,
Mercy Hospital does. For Kissy, and that was how I came to meet Shannon. The very first time she went to Kissy, she went to interview all the staff, all the stakeholders, in order to go back and create us a website. And so for Kissy, we have a website. And I think that department is still, that was our first visit to Kissy, just to do that. So I think maybe she's the right person to communicate that how each hospital has a conference, we can go about creating one.
in the meantime, Mary Beth has contact information for everyone that's here, and we can share that information. If you don't want your information shared to everyone, please let us know. But otherwise, we can share that through an email to each of you of who was here and what the contact people are and what their emails might be. And we can stay in touch with each other until the Sierra Leone Conference can get their website up.
Hi, if I could ask one question, and it's intensely personal, so bear with me. My name is Carol Stoner, and I'm a clinical nurse specialist in oncology by training, and I've had a certification through MD Anderson for cancer screening. So this is the second time I've heard something about the cervical cancer and breast cancer screening, and it kind of, I guess, surprised me a little bit. Being data-based, is there data that is showing an increase in the incidence of cervical cancer and breast cancer in Sierra Leone? And then coming from a cancer screening background, typically you only screen for things that you can treat. I mean, certainly if you have the ability to screen for things, but then the other ethical consideration is, are you screening for something that you have the ability to treat? So are you able to speak to that at all? Maybe it was just the pathology portion of the project that was the interest, I'm not sure, but are you able to speak to that at all?
Sure.
Okay.
We went, and I'll ask Carol to jump in with me on this as well. We took 4 people as well as support staff, myself, Dr. McIntosh, OBGYN, as well as an anesthesiologist, as well as Dr. Horner, who I'm sure you all know. And we wanted to do several things. We wanted to not only to do screening, but more importantly, to empower women to know how to do breast self-exams, and importantly, to teach the physician, Dr. Tejan, and the other physician who was there, how to do pap smears, how to do LEEP procedures, and then so that not only for cervical cancer screening, not only to actually do the screening, but what to do and how to treat people to prevent the development of truly invasive cervical cancer. Now, in terms of breast cancer, and you're absolutely right, one of the biggest challenges is we identified people who had very advanced disease, which is an enormous problem. Which is why we did do ultrasounds and exams and core biopsies to identify what type of breast cancer it is so that we can determine some treatment in terms of whether to provide those patients with tamoxifen, as well as to do some lumpectomies for those patients who had early disease. But you're absolutely right, it is an enormous challenge to not only identify patients, but identify how we're going to treat people who we do diagnose. If you take it then one step further and you say, not only at the local level, but at the national level, how do I identify whether there is an increase or decrease in the incidence of any types of cancer? It becomes an enormous opportunity for larger organizations like CORE, like the Ministry of Health, to develop a tumor registry. Because unfortunately, at least at this point, there is not a standing tumor registry, although there is discussion about the development of one. But it's only by having that information. It's interesting, if you look at the WHO data for Sierra Leone in terms of the incidence of any different type of cancer, there's no data from Sierra Leone. It's really just taking the data from surrounding countries and figuring it out based on the size of the population. So it becomes very important for us to begin to say not only what type of diseases are present, but whether it's changing over time. Now, having said all that, the reality is that breast cancer and cervical cancer, and particularly cervical cancer, is the most common, and it is very preventable. So I'll ask Dr. McIntosh to really comment on what the work that has been done in Zambia and in other places, and in Ghana, because cervical cancer is one of the diseases where it is not only treatable, but more importantly, particularly in this environment, it is preventable. And that's the most important thing.
So that was going to be just one other question. Are the immunizations going to include the HPV that we're starting in the United States? Is that a potential possibility for inclusion in immunizations for Sierra Leone?
Carol, do you want to go to Mike, Carol? She keeps talking without the mic.
I talk loud. You first have to get the data. So just the start of the fact that we went in there and started that, it starts the process. I mean, as Dr. Kirsten was saying, there's no registry. I mean, you have the military that's going around doing the death rates, and so you're not knowing exactly what is the actual death rate. What are people dying of? Is it cancer? Is it bleeding? Is it hemorrhaging because of cervical cancer? What is actually going on? Because they talk about the top 5, they talk about maternal health, but what's actually going on with cancer? Then the next thing is, as you said, the ethical issue of being treated. You can take it on 2 ways. Well, we diagnose and we can't provide treatment, so why should we diagnose? Or you can say we diagnose and point out that it is here, let's start finding out how can we treat. That's where you can start to take. So that's why I was talking about the collaboration. And the next step is looking at the surrounding countries. I mean, you do have countries that have a very good economy, developing collaboration between their Ministry of Health. Where it's in Ghana, are we able to send patients across to Ghana to have treatment and to come back in? Or are we able to bring in physicians that will be able to continue the treatment? In the sense of what we saw for cervical cancer and cervical screening, we did about 126 patients over 120 thin prep. We did what's called we put vinegar onto the cervix. I'll make it very simple. Put vinegar on the cervix, turned white, treated it. Now in Zambia, they had started that and went from put vinegar on the cervix and freeze it. And they noted there was a decrease in the cervical cancer. We did this, we did the leaps because we didn't have compressed air. We couldn't freeze. So we actually did the actual leaps. And out of it, we did 120. I've got back like about 15 leaps. All of them were HPV, meaning they did not need a leap. They did not need this further treatment. One patient had CIN3, which we believe is just that first step before cervical cancer, but we did not see cervical cancer. Now, we may not have screened well because we only had 120, and how we pulled the patient in, we may not have gotten that cervical cancer patient. But it did show us that what is being done in Zambia, where they are providing cryotherapy and showing a decrease in cervical cancer, can now be done in Sierra Leone. And there can be an impact there. But the next step is, and this is why when I heard about the generators, et cetera, is how do we get compressed air into Sierra Leone? How do we bring that into place? So it is a matter of finding out what is there, how to treat it, and then saying let's start to implement by using all the different resources and other countries around. Breast cancer, I believe, was probably more significant in the findings because it's advanced cancer. And not to talk about the different patients, but a 28-year-old to 52-year-old coming in with stage 3, stage 4. And there's no chemotherapy outside of tamoxifen. There's no radiation. And if you don't have the money, which may for us be $250, $300 to be treated, you're going to die. So what can we do there? That's another thing where Dr. Kirsten is talking about with the chloroquine. It may be just starting evaluation here, but that may be a step there. So again, I really do emphasize, I mean, we're talking about like the website, bringing people together. Yes, we really do need this collaboration so we know what everyone is doing, what's going on in McKenna and what's going on in Bow, because we may be able to say replicate that at least to start a registry, at least to start to understand, because when you start pulling data together, United States, President Obama made his initiative, Women and Children, that's our global health initiative, here in America and overseas. Give him the data and say, okay, we'll come to Sierra Leone. This is where we need the impact. So it's so many different aspects. I'm just, you know, again, it's like, I know we talk about like, oh my God, what's going on? I say, oh my God, look what we potentially can do. You know, and the fact of this coming together and bringing this out and trying to see how we can collaborate and also talk about collaborating with other countries and not reinventing the wheel, but bringing in programs. I think there's a lot that can be done. So, you know, it's great going to Sierra Leone. I'll go back again next month.
Okay, we'll take you.
Thank you very much for those responses. And as a nurse, I instituted a nurse-run cancer screening clinic. I was the only nurse in the clinic. So if there is that future need, somehow being made aware of that, or
we'll keep in touch.
Just one more comment. I guess it's pro-collaboration in a sense, but one of the reasons that I was interested in some of the conversation that Cindy and I had in Sierra Leone was that you've done the cancer screening, particularly the cervical, because my group has been working to get some funding to do at least early screening for cervical cancer. Here we are physically in the same location, but one of the reasons is that our physician, our surgeon, Dr. Maggie, has anecdotally found a great increase, but we need, again, to collect the data, in 27, 28, 29-year-old women with terminal cervical cancer. So if we can even get in and do the freezing, do the whatever to stop that, already we don't have legitimate data, but we certainly have some anecdotal data that those young women's lives would be saved just by that early level.
But even if you're with the Fistula Foundation, you know, someone West Africa Fistula Foundation, that's another group that's saying we're seeing
right.
Yeah. So how can we, again, the same thing, collaborate? We work with Dr. Maggi to actually evaluate the communications that we had from them. So again, I cannot emphasize saying what it is that we're doing and saying, well, how? I'm finding out about this, but you can do this.
Right, and I'm not a techie person, but I know there's some techie people in the room, and I'm wondering if there's a way to do a Yahoo group, or we have our own little kind of, I don't want to do a Facebook page thing, but you know, it's too public, but maybe a Yahoo group or some kind of thing where we can all just talk to each other and chat about, or post something. This is what we're doing. Anybody interested? Do you have any ideas about how to do this? Or something like that. Maybe we can get some help putting something like that together, because I think there's a lot of really good minds and there's a lot of really good hearts in the room with tremendous effort, and we should be working more together and collaboratively to make it all happen.
While the mic's going to Shannon, I'd like to move from the macro collaboration, which is really wonderful and it's great, to micro collaboration. In every community where we have a healthcare center, we also have a United Methodist Church. And in most of those communities, we have a United Methodist school. Obviously, I'm not experienced with all of these, but in a number of places where I have been, the school and the clinic and the church really are not related. They really are not working together. United Methodist Heritage has said that we are people who are to be doing good, avoiding evil, and we ought to be empowering our pastors and our church people to be collaborating in this healthcare program. And maybe we could look at, particularly in urban settings where there are nurses, you know, having parish nurses and other medical missionaries who could be working in the community and spreading our relationships and serving in a significant way. And then relating to that is, as we look at these priorities, what is the annual conference doing to meet these priorities and to begin? We cannot, as external partners, come in and do it. How are you all preparing to meet these needs and to meet your priorities?
Well, just something, not really to respond to Don's question, but as we were talking about cervical cancer and breast cancer, one of the things you need to understand is that it's very, very similar to AIDS. I happen to be one of the very first pastors in Sierra Leone who ever preached about AIDS in the pulpit and literally gave, condoms to our youth in the camp, and it became a scandal in Sierra Leone. And I was reported to the bishop, Bishop Bangura then, Bishop, you're sitting down here is your pastor teaching those girls and boys how to engage in sex by distributing condoms. It has to do with sex. And in Sierra Leone, our context is, and that's where we want you people, all of you, to really, for all of us to come together and see how we can go about it. A young girl or a woman, 18, 19, 20, suffering from maybe early symptoms, maybe of breast cancer, in a situation where maybe 1 out of every 10 medical doctors happens to be a female doctor. And a woman, cannot go to Dennis Mark, for example, to allow him to check at this breast to see whether there is cancer or any lump there. It's against our culture. It has to do with sex issue, and it becomes problematic. That's one of the things we really need to look at. It's a whole cultural issue. And we need a whole lot of civic education to change the mentality of our women that it's not about sex, it is about life. And in a situation where the American culture is now going everywhere around the world, talking about sexual harassment, about appropriate or inappropriate touch and all the rest of that, it becomes very difficult for even the male doctors to even attempt it. Even when look at it, every symptom points to the fact that that could be. But it becomes difficult for the male doctor to even say, let me touch your breast or let me just do that. And that's one of the reasons. So by the time the woman actually comes to the doctor, maybe it's out of control. So those are the cultural issues that we also got to deal with, let alone talking about cervical cancer. That's a different thing altogether.
Sure. Talking about cancer screening, the week before I left Freetown, there is a Think Pink organization. I think you've heard of that. Their office is next door to us. And the week I was to leave, they came to my office. The council director, the Connection and Ministries director, directed them to my office. And they want to start initiating visits to our churches to talk to women about breast examination. And I did direct them to the various churches, to the pastors, and there are some people who work in our office who are members of the churches. So that was what we have initiated, that, so that the women can start learning how to talk about breast cancer and how to do breast examinations. Think Pink is just next door to us.
I think that's a great way to start, is educating women through the church, but also if we could do further education with the nurses and the midwives who are actually seeing these women. If they don't want to have a male doctor examine them, they could have a nurse or a midwife examine them. And so it's something that's an education piece that we need to work on.
That's a question. Why don't you just address that? Because if we start, just address it from what happened in Rome.
Yeah, what we found, and you're absolutely right, it was amazing. When we started, when we started examining the women, we had all of the nurses and all of the student nurses intrigued and very, very interested in learning how to do breast self-exams, not only for themselves, but how to then be able to do it for their patients. And that, I think, is an immensely important thing for these people, so that by the time that we had left and by the time they were just as good as we were about doing it, they knew how to do it, and they were then teaching the women themselves how to do it themselves. So it wasn't about us. It was about teaching them so that they are going forward in a very self-sustaining, very empowering way, not only for the women themselves, but for the nurses and for the student nurses for the future of teaching them, and so that they are able to do it themselves. And that was the most important part.
Just to underscore your point, when I heard about your screening, team going to Bo, I happen to have had one suspected breast cancer, advanced, and she was a nursing student. I mean, yeah. I was so baffled to just learn that this is a nursing student with such clinically advanced breast cancer who did not know how to self-examine herself, which was going to prevent her to start with. Just when we were outside there, when sister introduced me to the doctor, and then I said, I referred the patient to you, and then she was looking at the data, and in fact, they have found out that she was stage 2. Was it what? Yeah, stage 2, the 29-year-old girl from Kisii. She was a woman from Kisii, and she was asking, so what do we do? I said, oh, I followed up on her, and she passed. Yeah. That was clearly a preventable death. And these are some of the things we really need to be undertaking. These are some of the things. Those are preventable deaths. We can do it right there. And then it broke her heart. It broke my heart. And, but I mean, we need to underscore that breast self-exam, and I believe you need to also go out and teach. When you go in the next time, make sure all the other hospitals, not only Mercy. I was supposed to go, but I was alone then. Actually, I heard about the trip. That's why I referred to you, but I didn't have the time to go because I was alone at my hospital. Yes, please.
And as I said, honestly, this is where we need you most. Because as I said, and from the example he has given, this was a nursing student. So just imagine the kind of training that is being offered to our nursing students in our nursing schools. And that underscores why there is every need for us to have a school of nursing. And then it also means he or the many male medical doctors cannot teach the females to go and do it. It has to be a female teaching a female how to scan or for breast cancer. And we will want as many of these teams as often as possible for you to really go back to Sierra Leone and help us do that. Because my wife, one of her best friends, died 3 months ago of breast cancer. And by the time, and it was associated with witchcraft. Eventually, she came and said she dreamt, and a cat in Africa, oh, Tombalin is not here. So he's not hearing that. He's not hearing that. In Africa, cats are associated with witchcraft. So she said she dreamt, and a cat bit her on the breast. And because she had that in mind, she said that's witchcraft. So she just resigned to read. Eventually, by the time she went to hospital, it was full-blown. It was really full-blown, and 2 days after she died. But this is where we really need you, as partners, especially, those and the females who are in the medical area. We can do a yearly or biannual program like that, where you all can go and we can advertise that in the national media and all the rest of it, and that you can really help to teach not only our own nurses, but nurses also in the government or also in the National School of Nursing and all of that. I think if we all do that together, it will be a big leap towards addressing that issue.
I just wanted to emphasize to not miss your point of having the school, the clinic, and the church. Because there's 2 points. One is that's where you can start with education when you're bringing it all together. Within the schools, are letting the young girls know not so much about empowerment, but to understand, to look at their bodies and be proud of it as God's creation. And that's where you come from the church, bringing it in. And then letting them to be aware of God also created doctors. So therefore, he talks about healing is healing the soul as well as the body. So that's how we bring the clinic in and to say to come out for health. So it is something where I do agree in the sense, not even micro, but to bring the 3 together. I'm going to bring another antidote from where we were in the clinic and where we were talking about providing the leaps, because I had one woman who came in who needed to do the leap. We're translating, and she was saying, no, 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 I'm not having it done, I'm not, saying no. And I had to keep pushing until finally she said, I have to ask my husband. Mm-hmm. So we called, and I talked to the husband, through a translator, explained, and he said, okay. So where are you talking about, yes, having women teaching doctors, female doctors teaching the female nurses, et cetera, then also the male doctors teaching the male patient to understand what's going on with his wife or his partner, and to say, come out for care, so that they can understand that it's okay for me to, as a male, to talk to you as a male about the health of your female. So it is something where on both ends to do it. And Mr. Edmonds, he pointed out within his community health, when he looks at the women and the children and he gets them in, he gets the men in. Because the woman is the one that, even though she is submissive to her husband, she is truly the one that keeps the whole family together. So we do you bring in the church and say that if the man is involved, because the women should submit to the man as church, just Jesus Christ loves the church, the same thing that he laid down his life, hey, please come and help your wife. So it's a whole collaboration, again, of school, clinic, church, as well as the male, female. Yes, we can talk about the cultural differences, but once education comes into it, that's not a problem.
I want to lift up the experience of when we did the Maternal and Child Health Week in net distribution. This health team in the Bow District did community outreach through our schools and churches and the health centers and the community health workers, which was kind of a mishmash of almost 4,000 volunteers. And the World Health Organization financed a study of that national campaign, of which the Sierra Leone UMC team covered Bow District. So they did 400,000 nets to cover Bow District. And after the review was done, the Bow District had more children under 5 sleeping under nets than any other district in the country. And when they asked people why did they use their nets, the number one answer in Bow District was, because my pastor or imam told me to. Because we very intentionally went through I don't know if it was the public schools or just the UMC schools, the team can fill in the details here with B, but all to say that this strategy has been done successfully by this team before. And to me, the conversation now shifts of, how do we coordinate and scale that up to include other health issues and interventions? I think that's kind of where we are. So what I would like to pose as an opportunity, again, we've got an organization who wants to strengthen that community outreach system. It's part of the health system, just like the hospital. And I'm happy, I think Beatrice and I usually start by evaluating health opportunities. She advises bishops and the health boards of what that opportunity is and what the community assessment process will be. But I'm happy to host, or as UMCOR or whatnot, the partners, all of us coming together in order to assess on a couple of different levels. If we're going to train up and spend money on understanding the baseline situation in terms of health of poverty of Bow, which is going to be required by this project, we might as well look at all of our issues and all of our systems and work it out together. So, and that's got to happen quickly, or we're going to lose the funding opportunity. So I'm leaving, so I'm putting this out there, and someone can hold me to it as you guys wrap up the meeting tomorrow. But I think that's one way. I'm going to arc to a connected issue. A point of information, again, I'm talking about imaginomalaria, which is, as I was starting to talk about earlier, for 4 years we've been fundraising as a church, and then on the other side of the ocean, we've been creating these teams that have the skills to advise how we're going to distribute those funds, and they compete for them, right? The Sierra Leone Annual Conference has to compete against Congo, compete against Zimbabwe, because the resources are finite. We started each annual conference health board. We're only in phase 1, which is that they apply up to $50,000. Once they perform well, they can apply for 100, 200, and we're going to scale up from there. Because again, we've never done this in concert, and we need to grow in a sustainable way. I just want to highlight that in terms of the priorities as articulated by the Sierra Leone team and others today, though the campaign is called Imaginomalaria, I really want to lift up that there are 3 areas that our health teams in Africa can apply. One is community-based primary health care, with malaria being the primary indicator, but that touches all these other issues: sanitation, environment, medication, kind of all the relatable issues around maternal and child survival in a community-based space, with malaria being the focal point, but not the only point. So we can train community health workers on a lot of different issues. So Imaginomalaria money can be used to do exactly what we're talking about with our community health workers on a lot of levels. Area 2 is infrastructure. Up to 80% of our hospitals, you guys know this, or the patient load at peak season is 80% malaria cases. And so purchasing, fixing the roofs, putting in water and septic systems, putting mattresses on the bed, for goodness sake, which is the situation in a lot of our rural places we don't have, are also, we can access in the case being made that we're providing for quality patient care by getting basic supplies into our health facilities. So a lot of these renovations and rehabilitations we can address through Imaginomalaria funds. The third area is training health professionals. These are our lab techs. These are our doctors, our nurses, incentivizing them to stay and work in rural, difficult situations. So I'm sharing this with you just so you know that, again, while called a malaria campaign, I think it addresses literally everything on this list and the other issues we have. But then I also wanted to take a moment to explain how that would work, which is the only entities that could apply for this funding are health boards of the annual conferences. So I'm going to give you an example of a place. So what that would look like in an example in another country In another country working with Africa, we were doing a net distribution. It was an old nothing but nets, so before we got into integrated malaria control. The health coordinator unfortunately passed away, but the government said, you've got to finish, this is the government timeline, UMC, you must finish this distribution. The bishop felt that the timeline was too tight and the loss was too great for the health team to do it on its own. And they essentially wrote the proposal for the funds and gave Africare operating authority on behalf of the United Methodist Church of Angola. So that means to say is that if there are different partners doing different work in any country, Sierra Leone or otherwise, with the blessing of the health board, they can apply for malaria-related interventions, like I just outlined, also and access these Imagine No Malaria funds. The trick is, because we're really trying to lift up this issue of ownership in our church, and it's a lot of the issue I hear, the tense conversations sometimes, the tension of the conversations today, it all does have to go through the UMC health board structure, which is something, again, denominationally we're working on. So a lot of information, I hope it's helpful, but I feel like I have to get it out there before I leave later.
Oh, it's very helpful. Thank you so much. Does anyone else have any? Dawn, go ahead.
I promise I won't talk tomorrow. Just one thing about the men's groups. One of the things that the Marie Stopes organization is doing in Freetown is that they have set up men's groups to discuss women's health and women's health issues. And I would think this would be a wonderful opportunity within the churches to set up men's group, going on Don's idea of even the parish nurses or that kind of thing, that they have their health educators talking to the men of various religions about the impact of their religious beliefs on the health care and the treatment of the women, and what different tests are about and what they're for and why certain things have to happen. And I found that to be a very strong idea. I don't know how well developed it is by Marie Stopes yet, but it was one of the things that they were working very hard on. And I think that could be adapted.
Thank you. Does anyone else have a comment or a question? I'm going to throw one out there, and Derek Reinhardt is so tired of hearing me say this, but one of the things that really, really would help the healthcare professionals trying to help in Sierra Leone is for the operations people to help us with power and water and sewer. And Derek would love to hear that, because that is really essential to health. And some of the equipment, like Carol said, trying to have compressed air to be able to do a treatment, you need power. And if you're going to have an operating room to do C-sections in the middle of the night, you need power. So anyone who has wonderful ideas about sustainable power and water and sewer issues, we'd love to hear from you. Thank you, Derek. I've been preaching to him for years now, so he hears me. So thank you very much. And I think, Mary Beth, we're moving towards taking a break and heading towards dinner. Is that correct?